Welcome back to the deep dive. Today, we are opening up a fresh stack of research from the Carlet Child Psychiatry Report, specifically the issue covering April through June of 2024. And I have to be honest with you, when I first saw the headers on these papers, clinical updates, pharmacological studies, I thought, okay, buckle up.
Right.
We are doing a deep dive into pure biology. Receptors, neurons, the hard chemistry of the brain.
Which is usually a pretty safe bet when we're looking at psychiatry. I mean, it is a medical field after all.
Exactly. But as I started reading through this, I realized I was completely wrong. The mission of this deep dive isn't actually about chemistry.
Right.
It's about language. It's about how the specific words we choose, whether we're naming a drug, describing a cultural behavior, or talking to a teenager about climate change, can actually determine if a patient gets better or gets worse.
Yeah, this is a really sharp takeaway. We often treat medicine as this objective, sterile thing. You have symptoms, you check the chart, get a diagnosis, prescribe the pill, the checklist.
Yeah.
But what this report makes incredibly clear is that psychiatry is unique.
Yeah.
It relies so much on communication. If you get the context wrong, if you translate a word incorrectly, or use a label that carries, a hidden stigma, the biology doesn't even matter.
Yeah.
The treatment fails before it even starts.
We have some, just mind-blowing examples of this today. We're going to look at how a translation error involving a rhinoceros, yes, the animal completely messed up a diagnosis.
I love that story.
We'll talk about why calling a drug an antipsychotic might actually be dangerous if the patient isn't psychotic. And we're going to look at crime and anxiety, which it turns out might not be anxiety at all.
There's a lot to unpack here. It's really about the power of, naming things correctly.
So let's dive right into the human context first. There's this fascinating interview with Dr. Dakota Carter on culturally competent assessment. Now, I have to be honest, cultural competence feels like one of those corporate buzzwords. It feels like an HR box you check so you don't get sued,
Yeah. Did you watch the diversity video? Great, you're competent.
Exactly.
But Dr. Carter argues that true cultural psychiatry isn't about memorizing that, like culture A does X and culture B does Y. It's about safety.
Safety.
It's about understanding the individual within their specific family context to create a comfortable environment.
Yeah.
Because if the patient doesn't feel safe, you are never getting the real story.
And he shares a case study that really drives this home because it's honestly terrifying. He talks about a patient, a first-generation Korean-American youth. She's an art student, doing well, but starts showing depressive symptoms that spiral into full-blown psychosis.
Right. And the context here is critical. Her parents didn't speak English. They wanted her to study math or science, the classic immigrant family pressure for a stable field.
Sure.
But when she started getting sick, they didn't bring her to a doctor. They waited. They waited until she became violent and actually ran into traffic.
See, that's the moment where I think a lot of clinicians, and honestly just people in general, would judge the parents.
Oh, absolutely.
You think, why did you wait? This is neglect. You let your child run into traffic.
Exactly. And Dr. Carter says that judgment, even if you don't say it out loud, it leaks out in your tone. It destroys the therapeutic alliance immediately.
Of course.
But here's the reality. The parents weren't neglectful. They were terrified. In their cultural framework, and specifically their family history, they believed this was spiritual. They thought spirits were inhabiting her because of a karmic debt, something the family had done wrong in the past.
So they thought it was their fault, but in a spiritual sense, not a medical one.
Yes. They were dealing with immense shame and fear of stigma. They thought they were being punished. If Dr. Carter had just said, spirits aren't real, she has a chemical imbalance, take this pill, he would have lost them. They felt completely misunderstood and dismissed.
So how did he bridge that? Because she did need the pill. She was in real danger.
He validated the context first. He used a phrase that I think is useful for anyone, not just doctors. Help me understand your concerns by listening to the spiritual explanation first. Without judgment, he could then explain that psychosis is a neuropsychiatric condition, not a punishment for their past sins. He actually relieves their guilt. Then, and only then, could they talk about medication.
It's almost like he had to translate the diagnosis into their moral language before he could even start using medical language.
That's a perfect way to put it.
Speaking of translation, we have to talk about the rhino story. This blew my mind. This is my favorite part of the report because it just shows how fragile language can be.
Oh, this is the perfect example of why direct translation fails. Dr. Carter talks about observing a resident, giving a cognitive test, the Montreal Cognitive Assessment, or MoCA, to a woman who spoke Urdu.
Okay.
They were using an interpreter.
And for those who don't know, this is a standard test, right? Like naming animals, identifying textures, drawing a clock.
Yeah, standard stuff. It's used to screen for dementia or cognitive decline.
Yeah.
But the woman failed the test miserably. The resident was ready to diagnose her with cognitive deficits.
Oh.
But Dr. Carter stepped in and realized the problem wasn't her brain. It was the test.
What happened?
One of the tasks is to name a picture of a rhinoceros. This woman had never seen a rhinoceros in her life. She couldn't name it because it just didn't exist in her world.
Wow.
And then the texture test. The interpreter asked her to identify velvet.
Okay, velvet seems simple enough.
Except there is literally no word for velvet in Urdu.
Wait, what? There's no word for velvet?
Not a direct equivalent. That
Yeah.
means that specific fabric texture. So asking her to identify velvet wasn't a memory test. It was a trick question.
A trick question she couldn't possibly answer.
Exactly. The interpreter was struggling to explain a concept that didn't have a label.
That is wild. You could misdiagnose someone with dementia just because your dictionary is bad.
It happens more than you think. The takeaway is that you can't just take a standardized scale, translate it via Google or even an interpreter, and assume it works.
Right.
You have to have a conversation. Dr. Carter points to the cultural formulation interview from the APA as a better tool. It asks these open-ended things like, what do you think is the cause of your problem?
It puts the patient's narrative first. It's about listening before you start labeling.
Yeah.
Okay, so that's the human cultural context. Let's zoom out to the global context. We have this interview with Dr. Laelia Benoit about climate anxiety, and this feels very, very relevant. I feel like everyone I know, especially younger people, is talking about this.
It is pervasive. The statistics Dr. Benoit cites are staggering. About 75 to 80% of young people, we're talking 15 to 25-year-olds, worry that climate change will harm their generation.
80%. That is a generational weight, a huge weight.
And it gets worse. 17% are losing sleep over it. 20% are considering not having children because they don't want to bring a child into this world. That's a massive existential crisis for a teenager.
It is. But Dr. Benoit makes a critical distinction here that fits our theme of language. She says we need to stop looking at this as a pathology. Climate anxiety is not a disorder.
Right. And this is so important. If a kid isn't sleeping and isn't eating, usually we say, that's a symptom, let's treat it.
Sure.
But Dr. Benoit argues that the cause here is rational. She calls it environmental grief. If your house is burning down, panic is the correct response. Treating it like a mental illness is almost like gaslighting the kid.
Like saying, you're crazy for thinking the world is warming when the world is warming.
Exactly. She brings up this term coined by Glenn Albrecht, solastalgia.
Solastalgia. It sounds poetic, but also kind of tragic.
It is. It's defined as nostalgia for home without leaving home. It's the distress you feel because your home environment is changing or degrading around you. You haven't moved, but your world has. It captures that feeling of loss perfectly.
So if we aren't supposed to cure this anxiety with pills, what do we do? Because the report mentions that parents often just stop talking about it. They think they're protecting their kids by being quiet.
And that is the paralysis trap. Parents think silence is safety. But kids interpret that silence as indifference. They think, Mom and Dad don't care, so I'm completely alone with this fear. Dr. Benoit says the antidote isn't silence, and it definitely isn't doom scrolling on social media.
So what is it?
It's action.
And this leads to what was honestly the most surprising case study for me, the autistic teen. This really turned my assumptions upside down.
Oh, this is a brilliant example of clinical nuance. Dr. Benoit was treating a teenager with autism who had what we call cognitive rigidity.
Yeah.
He was refusing to go on family holidays because of the flight emissions.
Okay.
He turned off all the appliances in the house constantly. He went strictly vegan.
And the parents naturally thought, this is his autism acting up. He's being rigid. We need to fix this so we can go on vacation.
Right, the standard interpretation. But Dr. Benoit said no. She argued that this rigidity was actually adaptive. He was responding logically to a threat. He was actually doing something to reduce carbon emissions. Instead of trying to treat or stop the behavior, she validated it. She supported his eco-rigidity.
That is bold, telling the parents he's right and you should probably listen to him.
It built immense trust with the patient. For the first time, a doctor didn't tell him he was obsessing. She told him his values mattered.
And that opened the door.
It did. That allowed her to form a bond with him, and because of that bond, she was able to work with him later on other rigidities that actually were harmful to his life.
So instead of pathologizing his passion, she used it. That's brilliant. And she gives some actionable advice for different ages, right?
Yes. For young kids, 5 to 12, keep it simple and positive, tangible things. Let's plant a tree. Let's recycle these bottles. For teens, it needs to be a collective action. Installing solar panels at school, joining a group. You need to feel like you aren't alone. And this is crucial. She suggests a counter-narrative based on facts. Remind kids that carbon emissions per person have actually dropped 17% since the 1990s.
I didn't know that stat myself. That actually helps my anxiety. C. Action and facts reduce anxiety better than silence.
Okay, let's shift gears to the third pillar here. We've talked culture, we've talked climate. Now let's talk about the biology, or rather, how we name the biology. There's an article in here about Neuroscience-Based Nomenclature, or NBN.
This is a huge shift in the field.
Yeah.
The current system we use is called the ATC system anatomical therapeutic chemical. Basically, we name drugs by what we originally used them for.
Like antidepressants or antipsychotics.
Exactly, which seems fine until, like the report points out, you prescribe an antipsychotic to a kid who definitely isn't psychotic.
Right.
And that is the problem. We use SSRI, so-called antidepressants, for anxiety all the time. We use antipsychotics like aripiprazole for Tourette's or irritability and autism.
And there's a story here about a patient named Maura that perfectly illustrates why this is a disaster.
Maura was a young girl with social anxiety. Her pediatrician did the right thing clinically. Prescribed desvenlafaxine.
Which is an SNRI, usually for depression, but also good for anxiety. Right. But her mom went home, did what every parent does, and Googled the drug. She saw antidepressant in big, bold letters, and she panicked.
Oh, no.
She didn't want her daughter labeled depressed. She thought the doctor had misdiagnosed her. So Maura never took the meds.
And then the mom did something that I think a lot of people would find surprising. She asked for Xanax instead.
Because Xanax alprazolam is classified as an anti-anxiety medication.
Yeah.
To the mom, the name matched the problem. But clinically, Xanax is addictive, sedating, and not a great long-term solution for a developing brain.
So the better, safer drug was rejected because of its name.
The label scared the family away and pushed them toward a potentially riskier drug.
Yeah.
The bad name literally led to worse care.
So how does NBN fix this?
It classifies drugs by what they actually do in the brain, their pharmacology and their mode of action.
So instead of psychostimulant, what would we call something like Ritalin, methylphenidate?
It becomes a dopamine and norepinephrine reuptake inhibitor.
Okay, I'm not going to lie, that doesn't exactly roll off the tongue.
It definitely doesn't. And that is the drawback. It's complex language, but it is accurate. It tells you we're treating a dopamine issue, not we're treating a psychosis.
It takes the stigma out.
It reduces the stigma. You aren't labeling the person, you're describing the mechanism. And it also seems like it would stop doctors from making dangerous mistakes.
How so?
Well, if a doctor knows that two different drugs are both serotonin reuptake inhibitors, they won't accidentally prescribe them together. Under the old names, you might combine an antidepressant and an anxiolytic, not realizing they both jack up serotonin levels.
Right, and that can cause serotonin syndrome.
Which is life-threatening. So again, accuracy in language isn't just semantics, it's safety. It connects back to the theme. Whether it's calling it solastalgia or a dopamine inhibitor, the precise term changes how everyone perceives the problem.
Now, before we wrap up, we have to hit the rapid-fire section. These are the logistical and research updates. First off, referrals. We know there's a massive shortage of child psychiatrists.
It is a crisis. There are only about 8,300 child psychiatrists in the whole U.S.
Wow.
So Dr. Sharmi Patel Rao outlines a strategy for stepping down stable patients to pediatricians.
Yeah.
Basically, if a kid is doing well, you move them back to the primary care doctor to free up your slot for a more complex case.
But she mentions this rule of 3 for referrals. What's that about?
This is a really important practical tip for anyone in healthcare, or honestly, anyone giving professional recommendations. When you refer a patient out to a therapist or another specialist, always provide at least 3 names.
Why 3?
If you give just one name, it can be seen as a specific medical recommendation or endorsement. If that provider messes up or commits malpractice, you could theoretically be on the hook for negligent referral.
Huh, I never thought of that.
Giving 3 options puts the choice and the agency back in the patient's hands. It protects you and empowers them.
Smart. It's like the Yelp rule. Never trust a restaurant with only 1 review. Okay, lastly, let's talk about the research updates on mania in youth. Specifically, ziprasidone is making a comeback.
It seems so. This was a study funded by Pfizer. Ziprasidone had a bit of a rough history. It was denied FDA approval for kids back in 2009 because of heart rhythm concerns.
Right, the QT prolongation thing.
Exactly. But this new study paints a different picture. It showed a decent effect, size 0.58, and the heart rhythm effect was very minor, but the big selling point is the metabolic profile.
Which means weight gain, right. That's always the big issue with these drugs.
Exactly. Ziprasidone is neutral metabolically. It causes less weight gain than many others. So for a teen worried about body image, that is a huge factor in whether they will actually take the pill.
And then there was a face-off, lithium versus quetiapine. Who won?
Well, it's a split decision. Quetiapine worked faster. In the first week, it was clearly better. Lithium had really high dropout rates early on, 75% in the first 3 rinse.
Wow, 75% dropout. That's high.
It is. People stop taking it because it's harder to manage. But, and this is the key, if you made it to week 4, the effectiveness was equal.
So if you can stick it out with lithium, it works just as well.
Right. But quetiapine gives you that quick win to stabilize a crisis.
So what does this all mean? We've traveled from Korean spiritual beliefs to climate grief to renaming drugs to the nitty-gritty of lithium dosing.
I think the red thread here is that accuracy in psychiatry isn't just about the right pill. It's about the right words.
Right.
It's using neuroscience-based nomenclature so a mom doesn't panic. It's using environmental grief to validate a teenager so they don't feel crazy. And it's using cultural humility to understand that when a family says spirits, they are neglecting their child. They are expressing fear in their own language.
It really emphasizes that psychiatry is a listening profession as much as a prescribing one.
Absolutely.
Here's where it gets really interesting for me, though. There's a tiny note in the source material mentioning that the publisher uses AI tools like ChatGPT to help draft some of these articles.
Yes, I saw that. It's becoming very common.
And it made me think, we just spent all this time talking about how crucial nuance is, how velvet didn't exist in Urdu and how that ruined a diagnosis, how a karmic debt looks like neglect if you don't know the language.
Yeah.
If language is that critical to mental health care, can we trust AI to handle it?
That is the provocative question, isn't it?
Will an AI understand the difference between adaptive rigidity in a climate-anxious teen and pathological rigidity, or will it just flag it as a symptom to be squashed?
It's a valid fear. I mean, AI is the ultimate checklist. And as Dr. Carter showed us, checklists fail when they meet the messy reality of human culture. We might get more efficient with AI, but we risk losing the very human context we started this deep dive with.
Something to mull over as you go about your week. Be careful with your labels, folks. They matter more than you think. Thanks for listening to The Deep Dive.
See you next time.